non-toxic nodular goiter. It may be a solitary nodule, multiple nodules. Let's discuss the solitary cold nodule, which occur in 95% of cases. The most common cause of a nodule is a solitary cold nodule non-functioning. It's palpable if it's more than 1 centimeter in diameter, and it occurs in 95% cases but is palpable only in 5% of cases. But ultrasound detects more. It detects 25% of the thyroid nodules and as small as 3 millimeters. These cold nodules have low radioiodine up, and the size palpation 1 centimeter palpable on ultrasound is detectable at 3 millimeter in size. They are non-functioning. So, what's a nodule size? A nodule of less than 1 centimeter is benign, and most patients have distorted thyroid nodules have fibrosis in them. So, in the nodule size, 1 centimeter less than 1 centimeter is usually benign. 1 to 2 centimeter has increased risk of cancer, and more than 2 centimeter has more risk of cancer. So when a ultrasound biopsy is performed in a nodule, if it's in 1 centimeter diameter and with microcalcification, is a feature of malignancy. Number two, if it's more than 1.5 centimeter and have solid or coarse calcification. Number three, if it's 2 centimeter in diameter or larger and has mixed solid and cystic component. So less than 1 centimeter is benign. 1 to 2 and more than 2 is a risk of cancer. And the ultrasound biopsy is performed is if it's 1 centimeter with microcalcification, more than 1.5 centimeter with solid or coarse calcification, and 2 centimeter in diameter, which has mixed solid and cystic component. And if a nodule is more than 4 centimeter, then it should be removed. So what percentage of the cold nodule become malignant? 10% may become malignant. Even 5% of hot nodules, which we'll discuss later. Let's discuss the radioactive iodine in cold nodule. They don't take the radioactive iodine. So this is a cold nodule here. This doesn't take the radioactive iodine. This one also in this here, which is a multinodular goiter, this one is cold nodule taking less. The hot nodule takes more radioactive iodine, excessive. This is grave disease, takes uniformly increased radioactive iodine. And this is thyroiditis, which doesn't take the radioactive iodine. Also malignancy. See here, this one, it doesn't take radioactive iodine. So the radioactive iodine uptake is low in cold nodule here and in the thyroiditis, in malignancy. It also takes low radioactive iodine in thyroiditis, acute phase of the thyroiditis. And then these hot nodules, they take more, and the grave disease takes more. So this is the cold nodule taking less. Cancer also takes less radioactive iodine. Cold nodule may be a benign or a neoplastic in 10% of the cases, and there develops follicular thyroid carcinoma. It has more distant metastasis to the bones and the lungs. Now the benign nodule. So the cold nodule, two parts, benign and malignant, and now benign may be filled with a colloid, may be inflammatory nodule, may be cystic. In one third of cases occur cystic nodule, or it may be a follicular adenoma. See, follicular adenoma is in benign nodule. Now, one third of benign cystic nodule and is diagnosed by the ultrasound, and it appears jet black on ultrasound. And hemorrhage in a cyst may cause pain, or it may cause localized swelling. Pain and hoarseness in a cyst may be due to malignancy also. Clinical features of a benign cyst. Most benign nodules are asymptomatic, slow growing, non-toxic, need simple follow-up without treatment. So the benign nodules are non-toxic, asymptomatic, slow growing. Fast growing may be malignant, need simple follow-up without any treatment. Investigation in a solitary or suspicious cold nodule is that TSH is normal, and FNA, fine needle aspiration biopsy, shows more than 70% are benign, and they are monitored by ultrasound. 20% are non-diagnostic and 10% are malignant follicular thyroid carcinoma that occur in 10 to 15% of thyroid cancers. So what's the ratio between the benign neoplasm and a thyroid carcinoma? That's 10 is to 1. 90% as I told are benign and 10% are malignant. So the ratio is 10 to 1 between benign and malignant. And male female ratio is 1 to 4, 4 times more in females. And what's the similarity between the cold nodule and a malignant nodule? Both of them take less radioactive iodine than the normal thyroid tissue. So, what are the indications for fine needle aspiration cytology or biopsy? Nodules of more than 1 centimeter with two ultrasound criteria of malignancy. They are microcalcification, hypoechogenicity, irregular border, increased vascularity. They may have extracapsular and lymph node invasion and have a history of head and neck radiation. So these are the indication for FNA biopsy. Nodule of more than 1 centimeter with microcalcification or hypoechogenicity, extracellular or lymph node invasion, and a head and neck radiation history of that. Now, features of the follicular thyroid carcinoma, which occur in cold nodule in 10% of cases, has trabecular or solid pattern of follicles, local invasion to the thyroid parenchyma capsule in blood vessels. Follicular thyroid carcinoma spreads more to distant organs, lungs, and bones. And the treatment of the follicular carcinoma is surgery followed by radiation or systemic therapy depending on the cancer stage. Cytopathology is non-diagnostic in 20% of cases. So what's the difference between benign and malignant nodule on examination? Consistency: soft in benign nodule and hard in malignant nodule. Size: small in benign nodule. Benign nodules are smaller and malignant nodules are larger. Mobility: benign nodules are mobile and malignant nodules are fixed. Growth is slow in benign nodules and fast in malignant nodules. Borders are circumscribed in benign nodules and ill-defined and irregular borders in a malignant nodule. Lymphadenopathy absent in benign nodules and present in malignant one. And then local invasion absent in benign nodule and present in malignant nodule. If there is insufficient evidence with rapid enlargement, then ultrasound guided FNA biopsy is done. If it's benign, then second biopsy in 2 to 5 years to confirm the benign status of the nodule. Diagnosis by ultrasound, CT, MRI. Then ultrasound advantages. Number one, ultrasound detects a non-palpable nodule, which is not palpable on examination. So it can find up to 3 millimeter inside. Ultrasound accurately localizes the nodules and selects the correct nodule if there are multiple nodules to take the sample accurately. Ultrasound differentiates between a solid and a cystic lesion and identifies adjacent lymphadenopathy and diagnoses suspicious nodules with microcalcification. So, what are the ultrasound biopsy indications on a nodule? So, I already explained it. Let's revise it. 1 centimeter with microcalcification, more than 1.5 centimeter with solid or cold calcification, 2 centimeter or larger with mixed solid and cystic components, and 4 centimeter larger may be removed. Now, what are the ultrasound characters of a benign nodule? Filled with colloid, not with blood, because if blood is present and it's malignant. So it's filled with colloid and edges are sharp and circumscribed and regular. Whereas ultrasound suggestive of malignancy are microcalcification, hypoechogenicity, irregular borders, and increased vascularity in blood. So these are the features of benign and malignant nodules, ultrasound features and advantages of doing a ultrasound on a nodule and a difference, examination difference between benign and malignant nodule. When we go to the treatment, majority are benign, so need no treatment, or otherwise levothyroxine or potassium iodide for benign solitary cold nodules. L-thyroxine suppression therapy for 6 to 12 months to determine if nodule decreases in size. And what the radioactive iodine does, It shrinks the nodule. Thyroxine treatment doesn't shrink the goiter, but radioactive iodine shrinks 50% size, and surgery for suspicious malignant nodule and follicular adenoma or follicular thyroid cancer. Total thyroidectomy followed by radiotherapy with radioactive iodine. The malignant cold nodules may be a carcinoma, a lymphoma, or a metastatic. The most common type of carcinoma, papillary carcinoma of the thyroid, occurs in 80% of cases, but is slow growing and it has local invasions. Lymphoma that occur in cold nodules are B cell non-Hodgkin lymphoma. And the Hodgkin lymphoma has Reed Sternberg cell, owl-eyed appearance cells like this. They are pathognomonic of that Hodgkin's lymphoma. Now, these are the features in ultrasound: hypoechogenicity that appear on malignant nodule, and microcalcification and irregular border. Hypoechogenicity, microcalcification, and irregular borders